Hello everyone, today we're going to continue our tour of Canada with the Canadian CT rules. So in this brief talk, we're going to review the Canadian CT rules and the Nexus criteria. Both of these are evidence-based and validated tools to assess if your patient needs head or neck imaging. So for the Canadian CT head criteria, you're going to get a head CT for patients who have a head injury and one of the following. If they have a GCS of less than 15, if you suspect a skull fracture or basilar skull fracture, if they have had 2 or more episodes of vomiting, if their age is greater than 65, if they have retrograde amnesia of 30 minutes or more, and if the mechanism is dangerous. So it's important to note that if you use an app like MD-Calc, they actually break these up into more serious and more mild criteria, which they use to tell you if you're going to basically be calling neurosurgery for your patient also. So keep that in mind if you use an MD-Calc, it can help you in that way also. One thing that catches my eye about these rules are vague things like dangerous mechanism being one of the inclusion criteria. So what is a dangerous mechanism for the Canadian CT head rule? These include pedestrian struck by vehicle, ejection from a motor vehicle, or fall from an elevation of 3 feet or 5 stairs. Any rule has exceptions, and the Canadian head CT rule is no different. It is not validated in patients less than 16 years old, so don't use it in your pediatric patients. And the Canadian head CT rule does not apply to patients who are having a seizure, have focal neurologic deficits, have a coagulopathy, or on oral anticoagulation. And that's because these are all independent indicators for a head CT. So if your patient has one of these, you don't have to worry about the Canadian head CT rule because each of these conditions or situations will point you in the direction of getting a head CT anyways. So now we are moving down from the head to the neck where we will be using the Canadian C-spine rule. And this rule, instead of just being a list of questions that you have to answer, is more algorithmic based. So the first couple times you use it, you'll probably want to have an algorithm like the one you see on the left pulled up so that you don't get lost. So you're going to start with, does the patient have any high-risk factors? That includes age greater than 65, a dangerous mechanism, or paralysis in any of their extremities. And if they have these, then they're getting some C-spine imaging, probably a neck CT. Any low-risk factors? If your patients have any of the following, a simple rear-end MVC as their mechanism, if they are sitting in the ED, if they're sitting upright in bed, if they were sitting upright in the waiting room, this is a low risk factor. If they have walked at any time, if they delayed in coming to the ED because they didn't have neck pain immediately, this is a low risk factor. And if they don't have midline C-spine tenderness, this is a low risk factor. So if they don't have any of those, then they're not actually low risk, so they're going to get a C-spine CT. If they do have one of the above, then you can proceed with more of your physical exam where you ask the patient to rotate their neck. If they are able to rotate their neck 45 degrees to the left and right, then they are in good shape and they don't require any C-spine imaging based on the Canadian C-spine rule. But if they can't move their neck, then you're going to get a C-spine CT. Earlier we discussed the dangerous mechanism for the Canadian head CT rule, and now we're going to talk about the inclusions for dangerous mechanism in the Canadian C-spine rule. Here we have the same fall from an elevation of 3 feet or 5 stairs, but now we have axial load to the head, a MVC while doing more than 60 miles an hour, a crash on some other form of transportation like a motorcycle, an ATV, a dirt bike, boat, or jet ski, or a bicycle crash. Another term to define is the simple MVC that is used in the Canadian C-spine rule and what is excluded from a simple MVC. So if that car crash pushes you into traffic, that is an exclusion criteria. If you are hit by a large vehicle like a bus or 18-wheeler or a vehicle at high speed going over 60 miles an hour, even if you yourself were not going over 60 miles an hour, you are excluded from the simple MVC. Or if your vehicle rolled over at any speed, that is also an exclusion criteria and gets you a head CT. By contrast, the Nexus criteria is a little bit shorter and easier to remember, I think. You're going to get C-spine imaging if any one of the following are present in your patient: a focal neurological deficit, spinal midline tenderness, altered levels of consciousness, intoxication, or a distracting injury. The abbreviation NSAID is a pretty good way to remember this. And I think this one is going to pay dividends if you commit it to memory early. I think this is one that you'll be more likely to get questions about just because it's a little bit more compact. Because these are evidence-based tools for decision-making, we should go over the levels of evidence for each of them. The Canadian CT head rule has level 2 evidence, which means it's accurate, but there's not enough evidence to demonstrate a change in patient outcomes. The Canadian C-spine and Nexus criteria both have level 1 evidence, which means both of these are accurate, can impact decision-making, outcomes, and cost. So, as you probably noticed, we have two methods to decide if a patient with a C-spine injury needs a CT scan. We have the Canadian C-spine rule versus the Nexus criteria. And how do you decide between the two? Well, a lot of really smart researchers asked that exact same question. And in a study with 8,283 people, they saw that the Canadian C-spine rule was more sensitive than the Nexus criteria, 99.4%, versus 90.7%, and that was statistically significant. The Canadian C-spine rule was also more specific, and whenever they examined how many patients would be missed by these rules, the Canadian C-spine rule would have missed only one patient, while the Nexus criteria would have missed 16. So they concluded that for alert patients with trauma who were stable, you should use the Canadian C-spine rule. And this is something that I think I have seen in clinical practice, but what I have gotten more questions about while on clinical rotations was about the Nexus criteria. I think because they're a little bit shorter and more easy to memorize, you might get more questions about these. These rules are really important, and even though you might not see them a whole lot on step 1 and step 2, you will definitely see them a lot in clinical practice, and there's a good chance on any shift in the ED you could not only use these rules, but be asked about them. So a good way to be prepared is to read about them beforehand and have a good way of using them in your decision making. So I use these resources to learn more about the different rules, and I think they're a really good place to start if you want to learn more. As always, thanks for listening.